Good morning, good afternoon, or good evening, depending on where you are. We are excited to have our webinar series here on Monday with Dr. Skorkowska. Did I say that close to correct? Can you hear me?
Yes.
Oh, perfect. Thank you so much for taking the time and coming to see us today. We're going to learn a little bit about visual field. We have quite a crowd of people coming that are logging on to see this, so I'm really excited to see this presentation and learn from the visual field background knowledge you have. You are both a glaucoma specialist and neuro-ophthalmologist, is that correct?
Yes, that's correct.
Great. And where did you do your training?
Well, I'm based in the Czech Republic, so that's where I studied the university and started my training. But I had the neuro-ophthalmology training mostly in Germany at the University Clinic of in Tübingen.
Excellent.
And now I'm back at home, and I work at the Santen University Hospital in Brno.
Excellent. And what's the current situation of the hospital? How are you seeing patients given this whole COVID-19? Are you actively seeing patients?
Mm-hmm. Well, in the region I live in, we fortunately did not have so many COVID cases. The most affected city in my country was Prague. But anyway, the normal situation in the hospital is probably now since Monday. Last Monday, it got much better. We opened our glaucoma practice again. Before that, we saw only patients with an acute problem. And now we also perform planned surgery like cataract surgery, glaucoma surgery, and so on. So the situation is slowly getting back to normal now.
Excellent. Well, I'm curious to see how the questions are regarding some of the thresholding testing that we get after your presentation. I'm eager to learn more about it. What I'm going to go ahead and do now, I'm going to go ahead and mute my camera and on my video. And we're going to, before we do that, I'm sorry, one more thing. We do want to ask a couple poll questions. So we wanted to go, which visual field test pattern do people routinely use for monitoring glaucoma? And you can, again, check all that apply for the ones that you're routinely using for doing it. And again, this is only for our participants, not for us to say here. And this question, I'm curious to see how that changes as we go through your presentation to see if people see a different test strategy that you're currently using that may be more helpful.
Mm-hmm.
So that's question one, and then I'll see what that answer was. Broadcast, so 24-2 is the most, I guess we probably could have picked that one.
Great.
And then do we have another question here? Are we going straight to the results? Straight to the presentation. Here we go, one more question. So which progression analysis strategy do you use when reviewing visual fields? Again, select multiple answers if you use particular ones for yourself. One other thing is, as we go through the webinar, if you have questions, please put them in the question and answer section, and we will come back to answer those immediately after the presentation is concluded. So let's go ahead and show what these results of this last question is. Mean deviations, that's pretty good. Mm-hmm. So now we're going to go ahead. Let's go ahead. I'll mute my camera here, and we'll get started with this presentation. Again, thank you so much for your time. I look forward to seeing and learning from you as we go through this.
Right. Thank you. Hello, dear colleagues. My task today is to talk about perimetry in glaucoma. This is the disclaimer slide. Glaucoma is defined as an optic neuropathy associated with characteristic structural damage to the optic nerve and visual field that may be caused by various pathological processes. And the most consistent of these is elevated intraocular pressure. Glaucoma diagnostics consists of several steps. And although we nowadays have modern imaging methods like the HRT or OCT, perimetry still has an essential role in the diagnosis and follow-up of glaucoma because it's the only method that tells you what the visual functions of your patients are. Perimetry in glaucoma should be static perimetry with a wide achromatic stimulus, size 3, and a threshold or fast threshold strategy. Kinetic perimetry, or the examination of the central 10 degrees or the use of a larger stimulus, is reserved for advanced glaucoma. But is there anything else that can be tested in your glaucoma patients? Yes, some advances have been made in the perimetry of glaucoma, and they are reflected in the newest perimeter of the ZEISS. It's called Humphrey Field Analyzer 3. And you can make use of these new features either after an individual test or when evaluating the progression in your patients. After each perimetry test, you can look at the single field analysis. And when you have performed several tests, then you can evaluate the progression analysis or the GPA. Let us first look at the single field analysis in detail. Out, you can find the reliability indices. Of all these indices that tell you how valid this particular examination was, the rate of the false positives is most important, and their rate should not exceed 15%. Further in the printout, you find the threshold values measured in your patient, either in decibels or coded in a grayscale map. I'm afraid most doctors look at this part of the printout when evaluating their patients, but this is enough if you have a patient with hemianopia, for instance. In a glaucoma patient, you should always check the graphs in the lower part of the printout. There you find the total deviation decibel plot, which compares the threshold measured in your patient with the age-corrected values, and this difference is displayed in decibels. In the total deviation probability plot, this deviation is assigned a statistical significance. So, if a black square is displayed at a particular location, it means that less than 0.5% of the population has such a difference at that point. Both graphs on the right side of the printout have the same meaning with one difference. The generalized depression in the visual field, which is usually caused by cataract, was removed, and so a localized visual field loss is more obvious. And these localized defects are typical for glaucoma. This is a practical example. On the top, you have a patient with cataract and glaucoma, which is a condition quite usual. And there on the left side is the total deviation probability plot, and this is the pattern deviation probability plot. And this graph tells you what the damage both from glaucoma and cataract is. And here you see the damage of the visual field caused only by glaucoma. So in a patient who only has glaucoma, both graphs are equal. And like this, you can evaluate which part of the visual field damage is due to glaucoma or cataract. When you have performed several tests, you can go to the guided progression analysis, or the GPA, where the progression analysis is summarized. Progression analysis can either be a so-called event analysis, which tells you whether progression has occurred or not, or it can be a trend analysis, which tells you how fast this progression was. The event analysis in a Humphrey perimeter is called glaucoma change probability map, and it tells you whether progression is likely or possible. The trend analysis, as I said, informs you how fast this progression was. And for this trend analysis, you can either use the MD index or the visual field index. The visual field index is unique for the Humphrey machine, and it expresses the visual field of your patient as a percentage of a healthy visual field. So healthy person with no visual field defects has a visual field index of 100%, and a perimetrically blind person has a visual field index of 0, and your patient may be somewhere in between. And if you plot this visual field index on a time axis, then you can observe how your patient is doing in long term and what his prospects are for the future if this trend continues. Why should we actually evaluate the rate of progression? It's because every glaucoma progresses, but the question is how fast the progression is. Without treatment, we are trying to save the visual functions of our patients as long as possible. And in terms of visual field, we want to prevent a significant visual field loss under -15 dB, which was defined to significantly reduce the quality of life in glaucoma patients. So if you then look at this trend analysis and have a patient like here on the left, who is progressing slowly and will probably have good vision by the time he's 90, then you can sit back and relax. But if you have a fast progressing patient like this one, who may get in trouble by the time he's 60, then you should do something about his treatment when possible. And it was found that it is important to define these fast progressing patients soon after the diagnosis. And in order to do this, you should test more frequently the visual field. In particular, you should perform 6 visual fields in 2.5 years. Because if you do the test only once in a year, then you don't know how to intersect the line. If you do more visual field tests, then you can lay the line easily with a narrow confidential interval. I have an example here of a patient who was diagnosed with such a visual field defect in one eye. And as you can see, I performed then the visual field test every half a year so that I can see if my treatment was effective. Because all this I was talking about, these 6 visual fields in 2.5 years, implies for patients who have a visual field defect at the time of diagnosis. These are most at risk. And I know the information of 6 visual fields in 2.5 years may easily be forgotten, so I found a slide that might help you remember this information, and I hope you like it. Well, I just told you that you should do more tests, but this takes time, and there are many people waiting outside of your office, and you certainly have other interests in ophthalmology as well. So what you need to do now is speed up. And I'm going to show you how you can speed up with the Humphrey Field Analyzer 3. You can use the 24-2 test, use Zeta Faster, and test central 10 degrees simultaneously with Zeta Faster 24-2C. 24-2 test has less points in the periphery compared to the 32- test, except for the nasal region, so that it takes less time to test, and also it has less rim artifacts. But on the other hand, the detection of a nasal step is preserved. So you can easily take this test for your glaucoma patients. ZETA is an abbreviation for Swedish Interactive Threshold Algorithm, and it is a fast threshold strategy which determines visual fields in a more efficient manner. It optimizes the determination of perimetry thresholds by continuously estimating what the expected threshold is based on the patient's age and neighboring thresholds. And like this, it reduces the time necessary to acquire a visual field, and it decreases patient's fatigue and increases reliability. The trend towards the development of faster strategies is obvious from this slide. As you can see, ZETA standard, which was released in 1997, took half of the time of the full threshold test, and the latest ZETA faster takes only 1/5 of the full threshold test. And if we look at the times in minutes, then ZETA standard lasts 5.5 to 10 minutes per one eye, whereas ZETA faster only 1.5 to 4 minutes. Of course, the duration of the test always depends on the cooperation of the patient and the degree of visual field loss. What makes ZETA faster? First, it's smarter starting values at 4 primary points. Then one staircase test sequence is performed at the primary points instead of 2. ZETA faster visual field model uses the distribution of ZETA fast normal values, whereas ZETA standard and ZETA fast had to take the normal values from the full threshold test. Further, no retesting at perimetrically blind points is performed, and an extra 300 milliseconds delay after non-seen stimulus was eliminated. The very important false negatives and blind spot catch trials are no longer performed. Let's look at some of these changes in detail. You save time already at the beginning of the test because the starting values at the 4 primary points are age-corrected normal threshold values, whereas in the other tests, it's always 25 decibels. False negatives are no longer registered because it was shown that the rate of false negatives is higher in glaucomatous visual fields. It's simply a property of the visual field, and the patient can do nothing about it. Like in this patient of mine, who has 0% of false positives, but the rate of false negatives is 14%. It's simply a property of his damaged field. Also, the Heil-Krakow method was replaced by gaze tracking. In the original fixation control method, the stimuli are displayed repeatedly on the place of the presumed blind spot. But just if the patient moves his head a bit, these stimuli may fall outside the region of interest. And so the fixation control is not precise anymore. So in this new program, this method was replaced by gaze tracking, and you can check it at the bottom of the printout. ZETA faster was tested in a multi-center clinical study and showed that it can save considerable test time. It gave almost identical results as ZETA fast, and there were only small differences between ZETA faster and ZETA standard of the same character as previously shown for ZETA fast versus ZETA standard. The last thing I would like to talk about is the central visual field in glaucoma. The usual idea of visual field progression in glaucoma is that the central visual field is spared until late in the disease, and a concentric visual field loss develops. But is the center of the visual field really intact? I performed a study on pupil perimetry in glaucoma some years ago. We used the stimulus pattern that you can see on the left, and the intensity of the pupil light reaction is displayed by the height of the red column. And as you can see, in the lower part of the visual or the pupil field, these red columns are smaller than in the upper part, and it corresponds to the visual field effect of this patient with glaucoma. And when we compared the pupil light reaction in glaucoma patients and healthy subjects, we found a significant difference at all tested locations in the visual field. But the greatest difference was in the center of the visual field, which does not really correspond to the classical idea of visual field progression in glaucoma. And at the same time, Dr. Hood published a study showing that glaucomatous damage of the macula occurs and can be revealed by OCT. But the problem is that the raster of the current perimetry tests falls outside this region of interest. It's simply not dense enough to detect this glaucoma damage in the macula. He also designed a chart showing that the lower part of macula is more vulnerable to glaucoma damage. And that is why you more often get a patient with an upper paracentral defect than with a defect in the lower part of the hemifield. So as you can see, glaucomatous damage of the macula can occur. It can occur even early in the disease, and it can be missed or underestimated with standard visual field tests that use a 6-degree grid. But on the other hand, it would be redundant to perform a 10-degree test on top of a 24-2 test in all of your patients. So with the ZEISS, you have the possibility to use 24-2C pattern that combines all 24-2 points with 10 selected 10-2 points. And so like this, you can test both the periphery and the center in one go. And then you can maybe get a patient like this who showed no changes with the 24-2 ZEISS standard, but when retested with 24-2C ZEISS, some significantly depressed points in the paracentral region showed up. Well, as you can see, there are modern methods or very sophisticated methods how to examine your patients with glaucoma. But I would like you to remember that perimetry is still a subjective method. The result always depends on the motivation and cooperation of your patients and the conditions for the test. So please have this on your mind. I hope my talk was helpful for your perimetry practice, and thank you for your attention.
Thank you for an excellent presentation here. We do have a lot of questions coming in that we're going to go through. So again, I'd like to know if one, we could go ahead and put those poll questions back up to kind of answer that. And what we're going to do as well is people look in so again, question number one, if you want to go ahead and repeat the question and see what the answers are. But for everybody, if you look in the chat window, Raluca is going to paste in there. The number one question we did get was on the sanitation of the visual field and everything. And there is a link directly to a ZEISS website that goes over all sorts of PPE that's available to cover the chin rests and things like this, and how to sanitize the bowl properly for what we believe is an effective communication to the sites. So let's go ahead and broadcast that first answer and see how that's changed. Wow, a lot of people looking to get 24-2C now that you did it. That's impressive. Let's go ahead and do our second poll question, then we'll go into the live question and answer session here. So again, we do have lots of questions. So again, here's the repeat question we had earlier. Whether the mean deviation, I believe, was the #1 answer for the first poll. We'll see if that changes as we go forward. And, let's see, once we get enough answers there, let's go ahead and broadcast again. And visual field index seems to be where more people have been swayed since we got through that. So congratulations. So one of the first questions I want to go over that came in is, can CETA faster be compared to CETA fast test?
Yes, you can freely change to another strategy without interfering with the progression analysis. So there's no problem if you change between all the CETA strategies. It doesn't affect all the analysis in the software. There's no problem about it.
Let's go to another one here. So this is an important one, I think. So it says 6 years, 6 visual fields in a year, question mark, which I think this is where I had the same question. So your slide says 2 a year. Is that an optimal strategy, or should it be 3 a year? What's again, can you explain the number of tests per year?
Yes. So the study of Belt-Johan that I showed says it should be 6 visual fields in 2.5 years. So about 3 visual fields in 1 year. And I understand that it may be too much for some practices. Even in my country, for instance, the insurance company pays for only 2 visual fields per year. But I think if you do 2 visual fields per year, it's still more than 1. And now I was not talking about patients who don't have any visual field defects. I was talking about patients who already have a visual field defect at the time of diagnosis. In those patients, you must be very careful. And in those patients, I would recommend to do a visual field more frequently at the beginning, let's say for 2 or 3 years. And then when you see that the patient is doing fine, you can prolong this interval and do the visual field every year, like in other patients. So it's only for the beginning, and I think 2 visual fields in the first years, it's fine.
Okay. And then I'm going to combine 2 questions here. One asks, is GPA available for the 24-2C, and do all machines have a 24-C strategy?
The 24-2C is available for the Humphrey Field Analyzer 3. But to be honest, I'm not sure if it can be updated on the older machines. This is more a question for the ZEISS specialists. But I'm afraid the 24-2C is only for Humphrey Field Analyzer 3.
Correct. And then there was another one I just saw here. What is your opinion for the best strategy to detect a progression of advanced glaucoma?
Yeah, that's a good question. Well, in advanced glaucoma, you can either use the strategy you were used to and maybe switch to the central 10-degree program. In other programs, no problem. Or you can enlarge the stimulus. What I also do, I do both of them. I change to the smaller visual field, and if the visual acuity is not good anymore, I also enlarge the stimulus.
Okay.
But now with the CETA Faster, it was interesting to read the study from Dr. Hale, who said that particularly those patients with advanced glaucoma were satisfied with this CETA Faster strategy. because they did not, there was not so much time waiting for a stimulus to come. It all went more faster and the patients were not so frustrated. But on the other hand, now there was another study I read that said that in the progression in those patients may be a bit underestimated. So I think the time will show, but it always depends on your patients. If you find that it works fine with your patients, you can also use that one, no problem. But what I do currently, I switch to the central 10-degree program or enlarge the stimulus, or both.
Okay. There's a question about, there was a paper about 3 years, supporting 3 years, 3 in a year. Is there a paper on that you referenced for doing 3 visual fields in a year?
Yes, that was a paper by Bell-Johan. I have it in the PowerPoint presentation.
I'll ask, we'll send that out in the post survey. We'll send out the link.
Yes, it's a very good paper. Yes.
That'll be helpful, I believe, for most people. So we can send that out. And then what's the visual field VFI, the visual field index threshold for interfering with the visual function?
What the visual field index, let's put it this way, with our treatment, we should try to prevent a decrease of visual field index under 50% in the better eye. If that is sufficient, I hope that is sufficient, and a significant visual field loss is defined as a loss of minus 1.5% per year of the visual field index.
Mm-hmm. Okay, so here's a couple more. We'll go through these pretty quickly though. Is there any literature using 24-2C with Plaquenil patients instead of a 10-2?
With
Plaquenil for toxicity of.
Oh, I am afraid there isn't any such paper. I haven't read such a paper.
We'll see if that changes if people start taking more doses of hydrochloroquine here, right? And then do you use Cetafaster for glaucoma suspect patients?
I think this is a program which may be very useful for those patients because Cetafaster is very good for screening purposes and for those at the beginning of glaucoma, for those with early or moderate glaucoma. If you have a patient who already has a visual field defect and who progresses and in whom you, for instance, consider a glaucoma surgery, then I would probably go to a CETA standard program. But for a glaucoma suspect or screening purposes, I think Cetafaster might be quite useful.
And so here's going to be another challenge to your system is, can you use, and I know you have a different billing strategy with OCTs and stuff in your area you mentioned, but can Cetafaster 24-2C replace OCT for detecting early glaucoma?
I don't think so. I think we always have to combine both structural and functional tests, because there are patients in whom the optic nerve looks fine and he may have visual field defects. And on the other hand, there are patients who have a normal visual field and some changes in OCT. I think those tests always will have to be combined and cannot replace each other.
Got it. And then do you currently have a strategy that you're using to disinfect your visual field? Is there any more than the regular steps you're taking currently?
I will have to start with the epidemiological situation in my country, because fortunately we are doing quite well. And we have maybe something like 8,000 cases in all the country. And for instance, today we had only 18 new cases. And we started with the perimetry examinations only a week ago. Before that, we didn't do any regular perimetry tests in our glaucoma unit. So we stopped for maybe 1.5 months. And now, and also there is one more thing about our country. All people have to wear a face mask, not only at home, but also in shops, but also outside. And when they come to the hospital, they all have a face mask. And they don't take it off when they are in the ambulance. They do the test with their face mask on. We have a shield on the slit lamp, etc. So what we only do now is we disinfect the chin rest and the button and so, but we don't disinfect the bowl now anymore because the rate of new cases is really low. So we don't consider it that important now.
Got it. Well, I want to thank you very much for your time. Again, we will send the link to everybody for that paper, as well as the instructions from ZEISS that we have for not only cleaning the instrument, but also disinfecting the bowl. I know that was always one of the big questions, is actually the bowl itself. So we actually do have some guidelines now that are out with that, allowing for the sterilization of the bowl. So again, thank you so much for your time. I hope you have a fantastic week, and I look forward to partnering with you again on future webinars.
Bye. Thank you.
Bye-bye.